Good afternoon, everybody, and welcome to the Team TSI sessions on the COVID-19 training. Today, we are really excited to be presenting some information related to therapy services. So looking at some of the impact and the considerations that all of you are having to look at with therapy, whether you're a therapist or whether you're an administrator and you have the therapists in your building. So really it's pertinent to all levels of facility and corporate levels. Today, I'm really pleased to have some guest speakers with us. My name is Pat Newberry, and I am with Team TSI in the Clinical Services Department. Also, we have Dahlia Croft, and I'll introduce the TSI group. We have Dahlia Croft, who's the Vice President of Strategic Relations. She's going to be helping me as our master trainer in the background, making sure your questions get fielded and answered. But we're really excited today to have as guest speakers a team from Rehab Care. We have Katrina Lempers. She is a DPT, as a practicing therapist and clinical coach for Rehab Care. She's been practicing for 8 years in different clinical settings and primarily with the geriatric population in both acute and subacute settings. She has a special interest in professional development and research, and that really has been beneficial at this point in time. She's been involved in a lot of internal research projects and has presented some of her findings at some of the different conferences. We also have Judy Freimuth, who is for Rehab Care the Director of Quality and Training. She's been practicing for 40 years in a variety of settings. The last 28 years, primarily in geriatrics in the SNF setting. She's also provided a lot of extensive education in regards to areas like seating and positioning and fall management, medically complex patients, which I think is going to be extremely important with what we're dealing with now. And then finally, we also have Stacy Fritiger. She is the Senior Director of Clinical Implementation for Rehab Care. She's been a physical therapist for 24 years, has advanced training as a certified exercise expert for the aging adult through the Geriatric Academy of Physical Therapy. And she's been practicing with the aging population for the last 19 years. So we have a large variety of experience in the geriatric and long-term care setting as we talk about dealing with this very special population. Also, I include on this slide, like we always do, our support team. So please don't hesitate if you ever have any questions. We always include support@teamtsi.com, and there's their contact information. So as you see, we give you Team TSI contact as well as the support team. I want to do just a little bit of housekeeping before we get started. I don't want to keep you too long in the things that are not important, but sometimes if you can't get in, these do become. So in the GoToWebinar audience view, if you're hearing me but you can't see, what you want to be able to do is to look it down at the bottom of your screen and you'll see that GoToWebinar. It's a blue flower and you click on it, and very often you will see just a bar. At the top of the bar, you'll see an orange arrow. It's pointing to the left. If you click on that arrow, what it will do is expand out the GoToWebinar audience view. And from there, if you'll scroll down, you'll see down the screen, you'll see an area that says questions. Because you all are in listen only mode, the way that you can let us know what your needs are, if you have any questions at all, whether it's technical, housekeeping, or clinical questions, type your questions in. When you click on questions, you'll see an area where you type them in. You'll see your question to make sure it's what you want and click send. And I have some people in the background. I'll have Dahlia Croft as well as Kelsey Little in our background along with myself, fielding and looking at those questions. What we're going to do with those questions as we go forward is our guest speakers will each provide a session. When they get through their section, we'll stop. We'll see if there are any questions to that point, and we'll continue on. Once we continue to, at the end, we'll make sure that every question that we can has been answered. If there are any that require further research, we simply will do some follow-up with you on that. So there will be plenty of opportunity and plenty of people in the background looking for the questions. The other thing that we want to make sure you know is that we do have the handouts available for you on this GoToWebinar pane. Right below the questions, you'll see the handout, and you just choose whichever one of these files and go ahead and download them. Now, if you can't get them to download, I'll show you at the end. You can simply request them and we'll email them to you. There are 3 handouts in this session today. The first one is the slide deck and what we're going to be going through in just a few minutes. And then the other 2 are some training materials that I'll talk about at the end and actually show you that we've just are providing to you. If you have not been on any of our previous webinars, then these will be new materials for you. We are providing them to you as our way of saying thank you to all of you that are out there serving this very, very important population of geriatric and developmentally delayed or disability residents. And we feel like that it's just our way of saying thank you. So we're providing some materials for you. So without further ado, I want to get this started. You don't need to listen to me talk anymore. We're going to start today with Judy. And so Judy, I'm going to just let you take this away here.
Thank you so much, Pat, and thank you to Team TSI for allowing us to partner with you today as we present this really valuable information. I think, you know, for all of us, but for everyone in the world, this is new, and each day we learn more. So it's important for us all to work closely together as we navigate through these unprecedented and difficult times. And it's really through sharing of knowledge with each other, sharing our expertise, sharing our firsthand experiences, that we will all be better equipped to care for and support our residents. So thank you so much for giving us this opportunity. In our skilled nursing facilities, we are really in a unique position where we are perhaps dealing with acute and or post-acute COVID patients at the same time that we're working diligently to recognize and address the impact that isolation and or confinement is having on our long-term care population. At the same time, we're also dealing with the impact that this pandemic has had on our institution and the challenges that we're facing in our efforts to safely care for and keep safe both our patients and our employees. So we felt it was important as we, we're talking about presenting today, that we really break this down into 3 sections. 1, let's talk about what's happening with our long-term care residents, what we're seeing and how we're addressing that. Let's have a conversation about acute and post-acute residents with COVID and what we're starting to see as we're getting more patients into our facilities and providing therapy services. And then lastly, the impact that it has on our institution and delivery of care and some of the things that we have done to help to navigate through that. So at this point, I would love to turn it over and to Katrina, who is, as Pat said, a PT practicing in a facility with rehab care and part of our clinical coach team. And there you go, Katrina, it's all yours.
Thank you, Judy, and thank you, Pat, and everyone at Team TSI, and all of you out there taking the time today to listen to today's talk, which is really important as practice evolves throughout this pandemic. As Judy mentioned, I'll be starting off today with a discussion on the care of our long-term care residents, which is a population that I feel could be potentially overlooked when we think about and when we're talking about COVID-19, because these people may not be directly impacted by COVID-19 as would an acute or post-acute COVID-19 patient. What I hope to share with you today is the importance of this population and to really increase the awareness of the role that therapy has on these indirect effects of isolation precautions and procedures which were implemented in response to COVID-19, which does impact this population. Isolation and decreased mobility, of course, place this population at high risk for multiple secondary complications, including weakness, impaired joint mobility and muscle flexibility, which increases the risk for contractures and impaired skin integrity, changes in urinary continence, impairments of ADL function, changes or a decline in cognition, communication, behaviors, feeding, swallow, falls, as well as impaired respiratory function. So there are a lot of areas, and they are multi-layered, that just being under isolation poses to this already vulnerable population. Next slide, Pat. So what I want to talk today about is what we have observed in the field so far and what we continue to observe by presenting sort of an example or a case study or a cohort study initiated in one of our rehab care facilities specific to the long-term care population. And basically how that started was through comprehensive therapy screening. Each resident on the long-term care unit was screened by physical, occupational, and speech therapy. And the screening that these therapists undertook when looking at these patients and continue to take into consideration multiple domains, which may not be typical when we're thinking about, a run-of-the-mill screening process of long-term care residents, because we are including behavior and mood changes directly related to not only the isolation, but the pandemic that's going on around us. We're looking at function and mobility, cognitive status, skin integrity, urinary continence, participation in already established restorative and functional maintenance programs. Within this case study that I'm presenting, 42 total long-term care residents were screened. And again, I just want to stress that these screening procedures have to be comprehensive because the declines that we've seen in the field are complex and they are multifactorial. Next slide, please. So, and what we found is that these residents are significantly impacted within a very short period of time spent in strict isolation. Within 2 weeks, we began screening these patients, a total of 42, and you can see some specific trends here and some specific statistics regarding each discipline and what percentage of the screened population had needs identified that would trigger a referral to one or more disciplines. But ultimately, within a 2-week period, 33% of the patients that we screened were referred for an evaluation by one or more therapy disciplines due to identified needs or a decline in one or more of those various multidimensional areas that we discussed. Next slide. We've observed some very specific trends while screening these patients. Changes in mood and behavior, which I've touched on, but we've seen an increase in anxiety and depression, agitation, decreased motivation or participation, not only in restorative or functional maintenance programs, but just in daily cares or just in their daily out of bed schedule. And these are exacerbated or triggered specifically to this isolation. We have seen changes in urinary continence that is not only limited to reports from the residents of an increase in urgency or frequency, but also medically diagnosed UTI requiring treatment. And finally, we've seen changes in intake associated with dehydration and in some cases, rapid weight loss. And these trends have seemed to create or have the potential to create a snowball effect whereby the decline that we see progressively becomes more and more and more severe. One example I want to use is that, say a patient has decreased motivation from not interacting with their family or not being able to socialize as they normally do, which results in less motivation to eat, resulting in a decrease in weight or rapid weight loss, causing improper fitting of dentures, which given the pandemic and the state of how things are, cannot be addressed promptly. So this, in this case, a speech therapy intervention may be warranted and result in a downgrade in a diet to a different consistency due to inadequate dentition. And it also it shines light that this is going to be an ongoing process. It has to be, because as things change in the future, when this patient may be able to get their dentition addressed, or they start to gain weight because of the different diet consistency that they've been placed on, speech may need to come back in and upgrade the diet once again to maintain that patient functioning at their optimal level. Next slide, please. So therapy department should consider increasing their efforts and really putting forth full efforts to conduct frequent, ongoing, comprehensive screening procedures with special attention to these specific areas of function: mood and behavior, depression, urinary continence. I would add on to that even the swallowing and feeding behaviors. We need frequent care coordination with the entire interdisciplinary team. This is essential to identify residents at risk and start the process of a referral to therapy when indicated. Okay, next slide. Also, the impact of COVID-19 on residents within this setting has provided great opportunities for facilities with activity departments to provide socialization, positive interaction in very unique ways. Connecting residents with families or support systems through FaceTime or other telecommunication platforms to boost overall morale, improve participation, and even complement what we're trying to do from a therapy standpoint. They can engage patients in one-on-one visits and provide meaningful interaction to provide, again, that patient with just a reason to participate in daily cares and out-of-bed mobility. And we have seen some really creative ideas out in the field to both promote interaction as well as patient well-being. Pictured here is a hydration cart in one of our facilities, whereby the activities department every day has music playing, they have beverages, they go to each resident and they promote hydration to prevent some of these risks that we have seen in the field and that I talked about, and maintain interaction in a positive way. Next slide. Finally, I'd like to touch on some strategies for monitoring long-term care residents by providing some of Rehab Care's best practices and guidelines, including comprehensive education to non-therapy staff on signs and symptoms of changes in decline, and when and how to make appropriate referrals to therapy using tools such as Rehab Care's considerations for referral to therapy. Another good one is the personal interest inventory, to kind of get an idea about what is meaningful to this resident and how can we provide for that in the current state that we're in and given these isolation precautions that we are all under. Some other great ideas. People are so creative out there to reach these residents, assigning buddies, you know, take a therapist and give them 2 or 3 long-term care residents to kind of monitor, visit regularly, frequently discuss that resident or those few residents with staff, and then refer to appropriate disciplines for screening if a decline or any of those subtle changes are noted, instead of you know, having 1 or 2 therapists be responsible for a large amount. You know, this is really a good way to effectively and efficiently manage time while still paying close attention and comprehensively screening these patients as we have recommended. Patient rounds, of course, with the interdisciplinary team, because, you know, we're so lucky to be surrounded by an entire interdisciplinary team whereby, you know, social services can clue us into, hey, this patient's not really as interactive, or they had a change in their, you know, depression score that we do on a quarterly basis. It might be worth looking into. Therapists who are already seeing a resident on caseload who happens to have a roommate, it's a great idea. The therapist can kind of keep an eye on that resident's roommate and be aware of any subtle changes and trigger that referral process and get it going so that we can kind of get ahead of that decline and help these patients while we can. Next slide. Screening our high-risk residents, you know, residents who we already know have a history of dementia or some underlying cognitive or communication deficits. Screening those residents currently on functional maintenance or restorative programs by facilitating communication with the restorative aides or staff members and seeing, hey, are they participating well? Have you noticed any changes, to trigger that referral quickly and efficiently? And finally, reviewing the facility CASPR reports to identify residents with a decline that has been noted per MDS is really a good way to double check and make sure that no residents are kind of falling through the cracks. So to kind of briefly conclude everything, the big takeaway ideas here are that the long-term care population is at great risk for decline in multiple domains due to isolation in response to COVID-19. These declines can occur very, very rapidly, so we need to be in there, and it needs to be ongoing. We're the experts in this department. We need to be involved. It needs to be happening now. It needs to be happening when things return to normal or when we get to a new normal and even beyond. And these observations from the field that I presented today strongly support the importance of therapy for patients directly and indirectly impacted by COVID-19. So I want to give it back to Pat now and open it up for any questions that might be coming up right now.
All right, I'm going to check to see. Dahlia, have you seen any questions at all?
Nope, so far we are looking good. Thank you, everybody.
Okay. And I see a couple of places where people have been raising their hands. Just to let you know, it's not something that we can connect with you. So if you will go in the question box and just type in your question, we will be in the background and answering those questions. So if there's anything you need, just go ahead and do that, if you will, please. So now I'm going to turn it on over, and I believe, Judy, are you going to be presenting the next series?
Yes, thank you, Pat. I am next. And the biggest challenge is going to be keeping my comments to 10 minutes. So off I go. So as we move into the discussion around therapy services as they relate to patients with COVID-19, I just want to spend a couple of minutes reviewing the signs and symptoms, the risk factors, and some statistics. So we kind of are laying the groundwork of what we're expecting, what we are seeing actually, and or are expecting to see as we're taking in patients with COVID or treating patients who have become acutely ill within our facilities. I'm sure that you're aware that there are a wide variety of symptoms. And I think, when this first started to come out and, we all became aware, fever, cough, dry cough, shortness of breath, fatigue, were kind of the general and are really the symptoms that are most common. However, over time, we're finding more and more different symptoms that are coming. And as we all know from things that we've read, we have people that are asymptomatic that do test positive. So additional symptoms of sputum production, myalgia, so achy joints, achy muscles, a sore throat, headache, chills, nausea, vomiting, nasal congestion, diarrhea, loss of taste and smell, conjunctivitis. Those are all different things that are seen, and some of them are over a period of time. The different signs and symptoms may start with one thing and then show some additional signs and symptoms. So those are just a quick review of what we might see for signs and symptoms, as well as, and I'm sorry, I forgot to get it on the slide, is cognitive changes. So I've read several things where someone has had an onset of confusion or some cognitive change, and then they find that person is testing positive. You can go to the next slide. And because there is so much going on and because we're learning so much about this new disease, it's important for us as healthcare professionals to read as much as we can. And sometimes we'll see things a little bit differently. I just wanted to show the Journal of Rehab Medicine and the report from the WHO, World Health Organization, from a partnership with China in a mission on coronavirus disease. We see asymptomatic or mild as 80% of the cases in the Journal of Rehab Medicine. The report from the World Health Organization is saying that mild to moderate is in that 80% and could be could be having non-pneumonia or pneumonia as well. We are seeing that about 15 to 13% of severe infection of disease, which is requiring ventilation for approximately 5%, just 6.1% as we look at one over the other. Approximately 42% of the patients rather admitted to the hospital are requiring oxygen. And from what I've read, what I've heard, what I've listened to, people I've talked to, the levels of oxygen are high. So one of the things we need to start to think of as therapists is, okay, we're going to have people that have never been on oxygen before who are now on oxygen, who also might be confused. So we have to think about teaching and training around managing oxygen and tubing and so forth. So, as Katrina mentioned earlier, with a long-term care patient, same with our COVID patients, there's this snowball effect because there's so much going on that one thing kind of leads to the other that leads to the next. So we really have to be very, very comprehensive in how we're looking at these patients. You can go on to the next slide. There are risk factors. Now, when we look at these risk factors, we're saying these are our people, 65 years and older, reside in nursing centers, pre-existing comorbidity, chronic cardiovascular disease, hypertension, chronic respiratory disease. If you think about the residents in your facility, how many of those residents have COPD or some other respiratory issue, diabetes, obesity, cancer, or other immunocompromised diseases, chronic kidney disease, liver disease. These are the patients that we see in our facilities, and this is why our patients are at such high risk for developing severe disease, according to the CDC. We can go to the next slide. When we are looking at the clinical presentation of the patient with COVID, there is a wide range of impairment. As I mentioned before, we have patients that have a very mild case or have no symptoms, and then we have patients that are very, very, very critically ill. So when we're looking at these patients, I think most of us think of respiratory problems. You think of COVID-19, you think of respiratory problems. But as time goes by, as more information is shared, we're finding that there are a wide variety of additional complications that are being seen with patients that have COVID-19. So dyskinesia or movement disorder or abnormal muscle movement, a wide range of cognitive and psychosocial disorders, including depression, anxiety, hallucination, behavior disturbances, etc. A very, very wide range of cognitive disorders. I was talking to a therapist yesterday who was saying that they're treating some patients for subacute care that have come from the hospital, and that they see a change even in the way the patients are presenting over the course of the day, from a cognitive status, able to follow directions, be engaged in the morning, in the afternoon, almost being in a kind of catatonic state. So a wide variety of things that we're seeing, and a variety of how we see them across, how they present to us across the day. Delirium, seizures, posterior reversible encephalopathy syndrome, myopathy and neuropathy, effects effects of the central nervous system. A stroke, they're seeing issues of thrombosis, so blood clots, stroke, symptoms of skeletal muscle damage. Again, a wide variety of challenges that they're seeing both in the acute stages and the post-acute stages. So when and you can hop to the next slide, when we look at these patients, we're really looking at medically complex patients. There are patients that have a wide variety of issues going on directly related to COVID, as well as comorbidities that were present prior to them contracting this illness. So most of the patients that we see as therapists in our facilities are medically complex patients, and our therapists do know what to do with a medically complex patient. I think that sometimes there's so much unknown and in addition to the unknown about the disease, there's also the infection control, the isolation that really makes people nervous. But as clinicians, we do know how to treat these medically complex patients, and we do know how to work with patients that have those wide variety of issues. If you can go to the next slide. So the areas, when we think about that they have the disease, and because of the disease and what's going on in the body as it relates to the disease process and how it affects the different systems, we are likely to see a variety of areas of impairment. So because of what happens with the disease, we see respiratory issues, we see shortness of breath, decreased endurance, etc. We see deconditioning or weakness. And a lot of that related to being, maybe in the ICU or unable to move around very much. A Johns Hopkins University study found for each day a person was on bed rest, their muscle strength dropped from 3 to 11% over the following months and years. So really important to be thinking about this deconditioning, weakness, and getting people moving early. We see neurological issues, muscle tightness, decreased range of motion, the development of contractions, again, secondary to immobility. When we have immobility and people not moving and having to stay in certain positions, perhaps prone, if they're in the hospital, in the ICU, as we have read a lot of articles, we might see then skin integrity issues that crop up related to immobility. Obviously, when you have those issues, muscle tightness, skin integrity, pain, we see pain. The cognitive issues, as I mentioned before, related to the disease process, but also related to being in an ICU, are going to be significant. And then communication issues that are related to decreased breath support, secondary to what's going on from a respiratory perspective, but also communications could be related to things that are going on from a neurological standpoint as well. Swallowing issues that maybe are related to what's going on, or, simple, even swallowing things related to weight loss. And as Katrina mentioned, then the dentures don't fit and then they have to downgrade the diet. So, and then obviously weight loss, et cetera. So these areas we see impacting function as we, as therapists, as we go to evaluate these patients, we're thinking of all of these different areas where there might be impairment. And you can move to the next section. So as a result of those impairments, so you have the disease process that is resulting in these impairments of weakness and respiratory issues and so forth, then we have an impact on function. And so what we start to see is, because of the respiratory issues, a decreased endurance, people that are able to do very little without becoming very short of breath or having their oxygen saturation levels dropped. We need to really be looking at them and thinking of energy conservation and work simplification. We need to go really slowly with these types of patients because they can only do very, very little, perhaps, before they're extremely fatigued. Mobility is impacted. Again, we have weakness, we have lack of range of motion and so forth. So bed mobility, wheelchair mobility. Think also we may be seeing many patients that have never used a wheelchair before, and now we're going to have to use a wheelchair for a period of time, and that's new. Transfer status, ambulation, the ability to take care of oneself, activities of daily living, bathing, dressing, toileting, eating. When we move even further in those activities of daily living, those independent skills of being able to cook and clean and so forth. Safe swallow, as we mentioned, communication, voice. If we have a certain neurological impairment resulting from the disease, maybe some issues around expressive and receptive language. As I mentioned before, a huge impact on endurance and tolerance. Psychosocial changes, and again, the cognition, as mentioned, could be executive functioning. When we're thinking of people that it may be younger and working and out in the community, how are they going to manage when they go home, and can they return to the workforce and manage their medications and so forth? You can move to the next slide. So there is so much for us to be looking at therapists. That the most important thing we need to do is a comprehensive evaluation. So making sure that we have PT, OT, and speech all involved as clinically indicated with our residents that are acutely in our facility or who are coming in for rehab services, making sure that we are doing that comprehensive evaluation where we're reviewing the medical history, the current medications, a very comprehensive physical exam, making sure that we're really doing a thorough respiratory examination, looking at function and cognitive assessments as well. We need to consider their prior level of function, home and work, and other psychosocial factors, including their support system upon transition out of our facility if they are going to another level of care or home. And through looking at all of these things and analyzing our findings as it relates to those impairments and those functional deficits, then we would each develop, PT, OT, and speech, a comprehensive treatment plan. And we can move to the next slide. So as we're looking again at developing that plan, there's so much for us to think about because there's so much going on with these patients. The World Health Organization defined medical rehabilitation as a set of interventions designed to optimize function and reduce disability in individuals with health conditions, whether they be acute or chronic, in interaction with their environments. And in the time of a pandemic, we're really looking at rehabilitation as management of the condition, which would be the impairments and disability, which we would identify upon our evaluation. We need to also prevent complications. So we need to be looking at what is going on with our patients, what possible complications could arise, and then we need to include caregiver education, patient education, to make sure that we're addressing those issues and working towards preventing those complications, which maybe could be issues around skin integrity, for example. We want to optimize functional capabilities through our treatment, and that's both physical functioning and cognitive functioning, as well as think about, again, that whole patient, that psychosocial piece, and how are we going to help them to reintegrate into the next level of care or home or within the facility. So I think a lot of the scary part about treatment, or not scary part, but the part that makes people a little nervous is that infection control piece. So we need to do all of this at the same time as we are considering how we're going to manage infection control and prevent further spread of the disease. So again, that treatment plan is driven by our evaluation and the status of the patient. So we may find that initially this patient is at a very low level and we're able to only treat them for a very short period of time. And maybe the big, from a PT standpoint, that big first thing that we're working on is bed mobility. And, we need to meet that patient where they are, that we find through our evaluation, and then move forward from there. Again, addressing all areas of impairment as they impact function. Our interventions, again, in terms of intensity and frequency, are going to be based on the acuity of the patient. We need to start really slow because of the respiratory issues. We need to be monitoring throughout our treatment. Heart rate, respiration rate, blood pressure, and oxygen saturation, which is going to be critical because these types of patients that we're seeing with these respiratory issues, their oxygen saturation can drop very quickly, especially when they're doing more activity. So close monitoring of those things is going to be critical and is going to help us to determine how we can move forward. Coordination of treatment between nursing and all therapy, so that we're all kind of rowing in the same direction and working on the same things. And as therapists, as well as nurses or anyone interacting with the patient, we have to plan every intervention. So before we go into the room and start treating, we really need to think about, what's going on with this patient? What are my goals? How am I going to approach this patient? Again, also thinking in mind the pieces around infection control. So how am I going to carry out this plan that I have? We want to make sure that we mobilize people early. Interventions in the hospital, in the acute care, in the ICU around range of motion and positioning and so forth is going to be critical. We know that people are going to become deconditioned very quickly. So we need to get early mobilization in order to prevent some of that. We can also be working on airway clearance through positioning and other breathing techniques. Again, we want to be very careful when we're working on proper breathing techniques and airway clearance that we are implementing appropriate infection control and using appropriately PPE. Sessions, again, may be very short initially. We really have to prioritize between disciplines, and within our own disciplines is what we're going to work on based on how our patient is responding to our treatment. And again, that constant monitoring is really going to be critical. For our patients as they progress, again, working with breathing techniques, but really important that we're going to be looking at energy conservation techniques, work simplification as patients progress and become more active. And as we all know, discharge planning begins at admission, and it'll be critical that when we are admitting these patients that we really are working together closely as a team to talk about the whole patient and start to make plans for this patient with regards to discharge or transitioning to the next level of care, if that is the plan, so that we can make sure everything that's needed is in place when the appropriate time comes. So that has been a lot. I think I would like to summarize by saying, you know, as therapists, we got this. We know what to do. We know how to treat patients that have these issues going on. It really goes back to a comprehensive evaluation and determining what is going on with this patient and meeting that patient where they are, closely monitoring and advancing them as clinically appropriate, not overdoing it. If your patients have a really good day, then don't push harder and do more. Always make sure we're monitoring and that we're thinking about that energy conservation and that we're pacing. Even when people are starting to bounce back and think that they can do more, we really need to be thinking about that because they can change significantly from day to day. As clinicians, we want to make sure, because there is so much information coming out, things are changing. The more patients we see, the more we'll understand and the more we'll know. So it's important for us to continue to educate ourselves, to ask questions, to seek support from our peers, from our professional organizations and our team. And thank you very much, Pat. I'm going to turn it back over to you for questions.
All right. I'm going to see, Dahlia, did you want to go ahead? And I see that there's been a couple of questions that, and maybe even some of, I think, really good comments.
Yes, absolutely. There has been a lot of wonderful comments.
I
Thank you all for
apologize.
that.
I went a little over on my time.
Oh, no, we're
So
perfect.
sorry.
No, this is good information.
So the first, I think, question and comment, but I know you're going to have some great feedback on this, is my biggest concern is loss of strength and increased falls. We're limiting our residents' use of the exercise bike equipment. Do you have any good suggestions to maintain strength when restorative programs are limited?
You know what I'm going to say, Katrina and Stacy, feel free to join in as well. I think that's one of the challenges too, because, all right, now we need to, we know, how am I trying to say this? We want to maintain, right, our patients at their highest level of function. We want to improve, but we know we have to do this all confined within the room. So really looking at being very creative in what we're doing with our patients in terms of activities. So maybe some marching, maybe some stepping up and down if you can bring in, you know, depending on the patient, and infection control if you were going to bring anything into the room. Obviously, you need to make sure that it's all disinfected and everything if you take it out, or if there are things that are left in the room, if it's safe to leave things in the room. But I think it's really tapping into the creativity of the therapist to say, you know, what is it that this patient can do? And then how can I mimic some of those things by doing different activities in order to help to maintain the strength and the mobility that they have, so that when time comes that we can start to do more, that they're able to do more. Katrina, do you want to pipe in with anything specific that you have?
Yes. So this is a really good question. And, you know, what I have found, you know, policies differ from facility to facility. I know there are some that are still allowing one patient at a time into like a restorative gym or a therapy gym. But, you know, if that's not possible, what I've really thought about is, okay, if to maintain their function, they need to do or use this piece of equipment, what is that piece of equipment really addressing?
Mm-hmm.
You know, what is that, you know, that exercise bike, what are we working on here? Are we doing it for resistance training of the lower extremities? Are we doing it for cardiovascular endurance training? Both of those things, all of those things. And, you know, just trying again to tap into that creativity and recreate in whatever ways that you can, because we're all kind of constrained right now, but recreate in various ways within the confines of the room or whatever you have to work with, to still address those same impairments at the maximal level that the patient can tolerate,
Mm-hmm.
if that makes sense.
It does. Yes, thank you. I've got another couple questions I thought I would ask you, and then I know that we have, I think, one more portion, and then we can even
Mm-hmm.
follow up with some more questions. But a couple good ones that I really thought you should know. Is it recommended that nursing staff, so actually it is recommended that nursing staff care for COVID-19 patients, only take care of COVID-19 patients? Is rehab care following some of the same protocol for therapists?
Stacy is going to, and Stacy chime in if you want.
Yes.
Stacy is going to talk a little bit about that in the next section.
Perfect.
Absolutely. I will grab that question in my bit, I promise.
Okay. Then that's perfect. So we'll hold on that one. And then do you want me to ask just that last one, or should we?
Sure.
Okay. So the last one for now is, not all COVID have to be hospitalized. However,
Right.
have you heard using a pulse oximeter?
Oximeter, yeah.
Thank you, oximeter, to check oxygen levels. Is this good to do for early detection for COVID pneumonia? What positioning is appropriate for COVID, stomach or side, to open the airways?
I think, and again, I don't want to just take over, so Katrina rather, and Stacy chime in, but just real quick, one of the things about the pulse oximeter, I think that personally, and you know, this is a little soapbox, we are going to be needing to use pulse oximeters as we're treating these patients throughout our treatment, because that is going to help us to understand if we're pushing that patient to fire, do they have enough oxygen moving around in their blood? And when we ask them to do more, then they're putting more strain on their system, and those oxygen levels will decrease. So it's really important that we are looking at that. I have read some articles that some people are looking at the O2 saturation, as I actually last night there was something that I read as an indication, but I'm not sure, you know, that would be something I suppose you would want to discuss with your physician, but you want to be watching that very closely, and whether that's dipping down, especially when you're asking the patient to do more. So it's hard enough to be keeping that oxygen level enough while they're at rest, but then when you're asking people to do more, then they're having to work even harder to keep that oxygen moving throughout. As far as positioning, you know, there's a lot of discussion around prone positioning, because that does help with the respiration. Side lying, I think the challenges with this population is because of postural deformities and deviations and other comorbidities, not all of our patients are able to assume those positions. So when we're looking at utilizing some of those positions, we do have to modify, given you know, the ability of our patient to assume those. So, you know, if you think about the patients in your facility, you know, I would say many of them could not get into a prone position, but they could get into a side lying or semi, you know, rotated kind of prone position. Katrina or Stacy?
Hi, I just wanted to say in regards to pulse oximetry, I mean, I think that is such an important tool to use, even in patients, again, I'm kind of biased about the long-term care residents who may not even have a COVID-19 infection, but we know that isolation can impact their respiratory function just because of the deconditioning that we know happens with less mobility. So using that just to gauge their respiratory, efficiency is a great tool. If you're seeing signs or drops in oxygen saturations that aren't typical for that patient, then it's certainly a reason to refer to the medical team for investigation, particularly during this time, but in my opinion, always.
Right. I think
Wonderful.
we're going to find that we need more pulse oximeters in the
Definitely.
facilities as we move. That's my feeling.
And I think
Wonderful.
we do have a couple more questions, but I'm wondering if we would be good to go ahead and go to the next section. This is Pat, and then see if some of those questions might get answered, and then we will answer them at the end, if that works out for everybody.
Perfect.
Good.
All right.
Wow.
So,
Yeah, we'll go to the final slide, and I'll
okay,
kind of put this all
Stacy.
together.
All right.
Yeah. All right. So our last slide, and we'll kind of wind down in closing to bring everything together. And our goal with this is to share what we've seen, what Rehab Care has implemented as some best practices and good strategies, and what we've seen our partner facilities do. Everybody, of course, is doing the best they can and learning as we go, because this is new for our world. Infection control, PPE, not new for us, right? But not to this degree. And of course, having some of the barriers and challenges to access the PPE that we want and need, as well as infection control taking a whole different, again, level for us, really, right? When we're not just talking about the residents that have tested positive, we're not just talking about a facility that has a positive unit or a resident with a positive diagnosis. We're talking about everywhere, even the facilities that have not yet had a resident be admitted with a diagnosis yet. We're implementing these new protocols and developing them as we go. So Rehab Care as a partner company, we're kind of in a unique situation, right? Because ultimately we are going to follow our partner facility protocol, period. We will help teach, train, guide. We have referenced them. Actually, I think Pat's going to talk about the Team TSI offering training on PPE and hand hygiene, which is one of the most thorough and extensive that I have seen. And we referenced our facilities to it as well. We're definitely taking in all the training and education that we can. We're following the CDC guidelines and staying up to date on those, sometimes on a daily basis is what it feels like, right? Of course, the foundational element being the proper hand washing. We're challenging therapists to think about how do you, as a therapist, which is very much a hands-on profession, just like nursing, just pretty much like every element in our facilities, can we put social distancing in place where it is appropriate and start to put, those extra parameters in there? Certainly we're using hand sanitizer any chance possible. We're constantly wiping down with Santa wipes, all high touch services, cleansing equipment all the time where it's being utilized as such. I think Judy kind of alluded to this as well. We're solving for this what we can right now. And I think we also need to be very forward looking that this will be ongoing for quite some time. If not, maybe this is some of what our new practices will be on a sustained basis. I think, we would love to see more face shields, certainly for our speech therapists, but probably for a lot of other folks as well in our facilities. We've been in a position as a company, we've been able to procure some PPE for our staff, surgical masks and gloves. We would love, we're searching for gowns and face shields just like you guys are, and hopefully we continue to see that expand. But some of the other strategies, and this next bullet point speaks to that question, absolutely. CMS, CDC, everybody has recommended we need dedicated staff. And where that is 100% feasible, we are absolutely doing that. We get that. There's definitely some situations where maybe there is one resident with a COVID diagnosis. So we can't dedicate a whole team to that, much like you guys probably couldn't as well, an entire floor staff you can't dedicate to one resident. But we are being cognizant of that. And so other strategies with that, well, if that patient is on our caseload, we're going to treat them the very end of our day. So that's sort of a dedicated team, right? I've treated all my other patients. I've followed infection control. I've utilized PPE to the protocol of that location. And I'm going to see my patient that's positive last, and I'm not contacting anybody else. I leave the building. So we're implementing those strategies where the volume and the staffing breadth or capability isn't there for us to dedicate an entire team. I will tell you, we are working through that on a case-by-case basis. If it's an absolute scenario, we're doing it. We will follow what we need to do for our facility and for our patients, but we're trying to think outside the box and get creative. We've said that word multiple times in this presentation. We're definitely having to get creative on how we're approaching our new world as that goes. So yes, and also thinking of different strategies when it comes to that question that was asked earlier. Initiation and continuation of treatment under a single discipline. So thinking that, are you guys familiar with PT, OT, and speech? There's definitely synergies between our professions and our treatment plans. So again, in situations where we're trying to limit staff contact with multiple patients or, across your units, is there a way perhaps, PT absorbs part of the OT treatment plan where it still fits into our scope? We're not getting out of those lanes. But we could take part of that OT treatment plan, again, as it complements, and then maybe that OT could back out for now, and perhaps until that patient's out of quarantine or we're able to look at a different strategy. OT and speech have some of those same overlaps. So again, I think that the integral conversation with the IDT and amongst our therapy disciplines to really talk through that and think of those strategies. One thing I didn't put on in here, in some locations, and actually we kind of challenged and educated all of our therapists to think about kind of triaging their caseload. Of course, if we've got a patient on therapy, it's medically necessary. We have deemed and under physician order that they need therapy services. But I mean, in an emergency situation like this, let's take a step back and let's kind of triage these into three categories: emergent, urgent, and non-urgent. And this actually, this originally came out with a governor's proclamation in Kentucky. And so emergent being that there is a high risk of irreparable harm within 24 hours if that patient is not seen by therapy. Urgent, and this is probably where the bulk of our patients fall, is that there's high risk of irreparable harm if that patient is not seen within 24 hours up to 30 days. So again, if I don't see a particular patient for 30 days, what kind of harm is risked in that? And that, again, we challenge our therapists to think about that. We can't put everybody on hold until this is over, knowing that there's going to be some irreparable harm when we don't see them for 30 days plus. So again, but that frames our conversation too, where we go back to the IDT and say, you know what, maybe we were at the tail end, we were planning discharge planning, and we were titrating down. We can look at this patient a little differently, but these absolutely, I mean, there will be harm if we don't continue our services. So how do we implement these other strategies and continue that? The third bucket being non-urgent is that there is a low risk of irreparable harm or no risk at all if that patient is not seen or that resident is not seen within 30 days. So that's a different strategy. That's somebody we want to follow up with later when this calms down, hopefully. So another strategy for us to look at, and again, guiding our conversations with the IDT. Alternating days. So again, certain situations, right, we have perhaps an evaluating therapist that maybe goes to two different buildings to complete the evaluations and the supervisory visits and the discharges. So that, previously that would be another therapist coming in and out of your building. So our strategy being, if the evaluating clinician is needing to come into your building that day, they are taking all the treatments for that discipline that day, right? The treating assistant would flip to perhaps the other building that the evaluating therapist was also going to. So we've got dedicated therapists for a full day, as opposed to maybe some of the back and forth. So that's been an effective strategy for us. Again, we're having to get creative and have a lot of intentional conversations and planning, but it's working. Again, it's getting our evaluating therapists in there occasionally and when they need to be at the right intervals, but we're dedicating that full day and decreasing the traffic that way. Leveraging technology, and you're going to laugh at me here in a little bit because one of my technologies is actually the windows of your building, but RehabCare uses iPads for our documentation, our electronic documentation. So we very, very quickly, hey, we've got FaceTime. in the treatment room or the resident rooms that we're still conducting treatments, we can connect people with their families and how, I mean, again, it's part of the treatment and it's a social connection. I can also do some caregiver training that way. I'm with the patient, I'm doing direct therapy, so it's not telehealth because that's not quite allowed yet with Medicare, but I'm using the device to connect my patient with their family members. How cool is that? And we've gotten some amazing stories that give you goosebumps and make you cry on kind of the success stories of that. And again, we can incorporate some family training, discharge planning, those kinds of conversations in that as well. We also, CMS has recently said, if we've got that evaluating therapist on site, potentially even in your foyer, and we have a treating therapist in the room with the patient, again, we're decreasing the number of people coming in contact with your residents. We can use the FaceTime technology, and that counts as a supervisory visit. CMS has totally cleared this in language for us. So again, I'm an evaluating PT. I could be standing in your lobby. I can FaceTime with a treating assistant. I can see my patient, and we can talk through a bit of, see some activities, do some instruction, and I can then guide a treatment plan and continue on from there. So leveraging technology that way. The windows bit, that also CMS basically said too, if the therapist can see a resident through a window, again, with a treating assistant in person with that patient, that also would be a strategy to implement to get clinicians as close as possible to the patient and continue our treatment plans and assessments that way. So I hope you all have seen, there's some just amazing photos and stories out there of how we've connected people to loved ones, but then we've still been able to access these patients for some treatment. That's been pretty exciting. Assisting partner facility floor staff. So this is another thing. Again, if let's say we've got a dedicated full therapy team in your building, we're comfortable with that. This is the only building they go to. We've got proper infection control in place and PPE, but you need help on the floor, passing trays, doing things that we can partner with you to do. It's kind of additional services, but we are all in this together. If we're in your building and to reduce risk and additional exposure, if there's things we can help you with, we want to help you with those things. And a lot of those for the patients that we're seeing under therapy, we can incorporate that as part of our treatment plan. We have to get creative, but there's that word again, but we can absolutely do that. Dedicated units. There are lots of things I've heard that I think are pretty fascinating. Initially, to me, I just thought, sure, if you up in New York, sure, we have dedicated positive COVID units. We don't see that a lot. I'm in the Midwest. We're not totally seeing heaps of that yet, but I'm hearing some effective strategies. So all new admissions quarantined for the first 14 days. So they're going on this particular unit and they are quarantined for 14 days because we know some people are asymptomatic and we don't know where they came from or who they've been in contact with. So all new admissions being quarantined for 14 days. We've heard stories if there was a positive diagnosis on a particular unit, employee or a resident, quarantine that whole unit for 14 days, right? Those are they're aggressive strategies, but they are working, and they're certainly confining any spread of positive diagnoses. So those to me again are really good success stories. We've also heard of people doing like a dedicated therapist room. So again, I'm your evaluating PT. You give me this little bitty room. It doesn't even have to be big, right? Big enough for me and a patient, and that's my room for the day. And floor staff would be bringing patients to me. We would completely sterilize, clean the room in between each session. Again, that keeps me from moving around the building, coming into contact with people that are even not on my caseload. But it's really keeping that contact and all of that pretty limited, but still enabling us to continue to treat these patients. Again, go back to those urgent and emergent kind of triaging mentality. Think about all the side effects of the isolation, and we're seeing it. We're already starting to see the detriments of the isolation. It's that balance, right? We're protecting residents from infection and the spread of this, knowing that there's a give and take and there's a negative effect of isolation, and we've got to do both. And what a huge burden that is. But certainly, I think some of these strategies have been pretty effective. Don't forget those other strategies that Katrina and Judy both talked about, right? Casper reports will tell the story straight away, right? And that's a good guide even as we start to be thinking about, I use the word recovery, but think about recovery coming out of this, coming out of the isolation. CASPR reports would be a great start. That intentional screening plan, again, intentional. We have to be very focused, triage even how we're going to screen and approach that. And then I guess ultimately I would say leverage the expertise of your therapy partners. As Judy said, Katrina said the same thing. All of those the side effects of isolation, the impacts of isolation, what we're seeing with post-COVID diagnoses and post-acute hospitalizations with COVID, we treat those things, and we're your partners in this. So look to us as part of your strategy moving out of this as well. One thing I thought was really cool is that I will share this in closing. I was on a call this morning with our executive team, and one of the DVPs shared kind of a positive out of all of this, right? One thing we've absolutely seen with our partner facilities is this is hugely increased communication, and that the level that we're approaching conversations with and decisions with, transparency, just absolutely 100% has to be in place on both sides. And I think overall, it has just strengthened our partnerships and how we are all either focusing on the residents and doing the best we can, sharing strategies, sharing best practices of things that have worked, sharing PPE when we can, sharing staff when we can, right? It's just about doing the best we can and everything we can in this current situation. So with that, Pat, I think we can, if there are some questions we want to wind down with.
Yeah, well, I think that's good. What I want to do is to go ahead and finish a couple of little thoughts for myself, and then just to let everybody on the call know, I know we're going a little over. We're going to go ahead and continue if the team doesn't mind, Judy, Katrina, and Stacy, that we'll continue to answer questions, but also Dahlia and I will put together a Q&A doc if you have to drop off because we know you're busy. Don't forget, we will have a recording, and we can also do a Q&A doc that we can send out to everybody as well after this call. So if the team doesn't mind staying on a little bit, what I'll do is finish up my piece. We'll go into those questions, and then but we will also send out to all of you on the call today that may have to drop off because we know that we're running a little bit over. We've got such good information that we just didn't want to stop. So with that, I'm going to pop over really quickly. One of the things you'll have in your handout, and thank you so much, Rehab Care Team, for providing, and this is references of where a lot of the information that they've been able to give you, besides the benefit of their knowledge and how things are being done and some strategies. The other thing I want to remind everybody, you do not have to be a member. The APTA, the American Physical Therapy Association, the AOTA, the American Occupational Therapy Association, and ASHA, American Speech and Hearing, and I'm going to get that one wrong, Association, ASHA. They are all providing a tremendous amount of resources for you all. And even if you're a member, certainly you have more depth. But even if you're not a member, you're a facility administrator, there's a wealth of information for you that will help you. So I want to make sure all of you know that. The other thing that I want to talk just a little bit about are some things that kind of tap into what all three of the speakers have been talking about. These are some things to think about. Don't forget that CMS is doing, as well as we're hearing OSHA as well, are doing some focus infection control surveys. And they're focusing very specifically on hand hygiene and PPE use. So as you start as therapists or as other interdisciplinary team members and you're getting your therapist to team up with you, which is really the perfect way to have a true interdisciplinary team, you want to make sure that what I do as a therapist, that may be everyday practice and I've got my competencies, I know, but if I'm doing something to help out that may be just a little different, you want to make sure that your staff, that your therapy staff has the competency checklists. If they're passing trays, if they're doing temps, it seems simple and little, but when the team comes in to do these focus infection control surveys, they're going to look to see if you've got therapists doing things that are not within what they normally do. Do they have the competency checklist? So don't forget to get those. The other part of that is they're going to be looking very carefully, as the speakers have been talking about, they're going to be looking very carefully at your hand hygiene practices and your PPE practices. And if I'm a therapist, I'm pretty comfortable with my treatments and how I maintain those practices. But if I'm stepping into another role to help out, I may forget that. So it's always good to go back and retrain everybody and provide that. In your handouts, and I will thank Hugh Heaton for this because he developed 2 wonderful resources for you guys. Please share it with your staff, with all of your team. This is something that Team TSI and Hugh Heaton are providing. It's our contribution to you all as caregivers to thank you for everything that you do. And these are 2 training programs that are training in a box. It has everything from what a trainer needs to do. It has the handouts with all the notes for a trainer. It has a handout section for the people attending. It has a section where you've got competency checklist, post-test, certificate of attendance, everything that you need to fulfill what the surveyors are going to look for in this focused infection control survey is all in this package, and we've provided both of those handouts to you. So I want you to please take advantage of them. If you can't get those to download from this handout section, don't hesitate to send your questions to Team TSI, training@teamtsi.com, and that will provide that we will send out the recording for today, which has all of it, as well as all the handouts, both what we've gone over today, the handouts that are in there, and then the Q&A document that we will put together for you. So if you guys don't mind, if Dahlia, if you've got some additional questions that you might want to ask again.
Absolutely. The first one I'd like to start with is, can we have Stacy talk about the 3 stages again that she had mentioned? That part is really getting a lot of great feedback, the urgent, non-urgent, etc.
Absolutely. Yes. So the 3 are emergent, which is a high risk of serious or irreparable harm if a patient is not seen within 24 hours. Urgent, which is that same high risk of serious or irreparable harm if the patient is not seen within 24 hours up to 30 days. And then non-urgent would be those residents that are not at a high risk and would likely have no impact at all if they were not seen within 30 days or beyond 30 days. And so really looking at in those windows of time, if a patient was not provided skilled therapy services, what would be the risk and detriment? And I would say it's my opinion, and Katrina and Judy can add in, I would say most of our patient population in this setting falls into the urgent category.
Mm-hmm.
I guess I would say some of the acute hospital discharges of a positive COVID diagnosis, that maybe is in the emergent department. I think we would want to have no gap in time in their treatments, but most are in the urgent category.
Agree.
Wonderful. I think this question goes back to maybe when Katrina was talking about the buddies, and I may have had that wrong, but if we assign buddies to therapists, how does this work and remain productive for the therapists?
So the idea behind assigning buddies is really to mitigate and most efficiently manage time. It may not be, quote unquote productive, but by spreading it out and giving each therapist, 1 or 2 long-term care residents where they're checking in at regular intervals, it becomes productive because you'll be able to notice those subtle changes more efficiently, and will be able to intervene and refer for needed services based on the needs identified much more quickly. So it's kind of in the long term, it becomes a very productive way of monitoring those long-term care residents. And Judy, Stacy, feel free to jump in if you can elaborate on anything or if you have more input on that.
Yeah, go ahead, Stacy.
what did you say? All I would add is it's really no different than what we would do on a daily basis anyway. It's just now we probably have to get behind the door to their room, right? And respectfully so, and following infection control. So yes, that would take a little bit more time, but your therapy partners should always kind of be, stopping in the hallway to say hi, or stopping at the dinner table to say hi, because that is kind of still us checking in on everybody and owning some of that responsibility in your facilities, that we have to keep everybody at their highest functional level at all times. So.
Right. I agree. I think it's something that's incorporated into the day. That doesn't necessarily mean you got to spend 10 minutes with every one of your buddies. It really is incorporated into your day, checking with the nursing staff, poking your head in on the patient. How's it going? Again, if you're treating one patient in one bed and the buddy's in the other bed, you're observing while you're with your patient. So there's a lot of ways that I don't think from a time standpoint it would be a huge impact.
Wonderful, thank you. I think we really have had, like you said, Pat, so many wonderful comments. I'm not sure if we want to bring some of those up. I think the last true question is, how often should staff be cleaning doorknobs, et cetera? And I know that may kind of go more into the hand hygiene and some of the infection control. What do you guys think?
I'm giggling to myself because I'm cleaning doorknobs in my house all the time. But I agree with you. I think that goes into the infection control, hand hygiene thing.
Right. And I don't know if there is a recommended
I don't either.
Right. I mean, I think we're trying to teach and implement, as anytime you have touched a doorknob, right, even if you have gloves on, because I think that's one thing we're seeing even in the community. People are putting gloves on, and then they're touching something, then they're going and touching something else, and you're like, okay. So it's just, I mean, of course, I would say this is a non-answer, but anytime you can and you're walking, you can grab a hand sanitizer wipe, I would, and I'd wipe doorknobs. But.
Right, and it, obviously, if something's visibly soiled,
sure,
anyone would.
Definitely. Yeah. And I can speak to kind of like in my facility, kind of we have certain procedures, policies, and of course, if it's soiled, of course, if it's touched with anything that's contaminated, but then also at a minimum twice per day, and we're documenting that. That we have cleaned every single surface within our gym, whether a patient has been in there or not. And the minimum recommendation is twice a day, in addition to, of course, if you notice, contamination of any kind.
That's great.
Yep.
A couple of the comments that I really don't want to end without, I think, at least bringing them up, and maybe you may have some information that you'd like to share or add to, is we had some comments about there's almost a COVID sundowning that is being seen, by some therapists. There is, critical to stress of the COVID-19 residents, that they need care even more, than the long-term care residents that have been isolated. So screening, how screening is extremely important. Again, kind of more of a comment, but great information. I don't know if you guys want to add to any of that. Therapy gives exercise programs that all staff can perform with residents. And like you're saying, I've seen so many wonderful stories that absolutely get to my heart and tears sometimes, but I just love the creativity that we're seeing and all of the great stories, but that's a good comment.
I'm going to interject something that I heard earlier today, and actually it's our student relations department. So because we can't take therapy students right now, right? So they actually, there's been a group of students who are producing YouTube videos for exercise, so therapy-based exercises. So again, it goes back to, can we leverage some technology? I think back to somebody posed that question to Katrina. We know somebody might be, or we know they're at risk to deteriorate with strength or aerobic capacity in their room. What can we do? I don't know. Do they have an iPad or something where they could watch, potentially some of these YouTube videos that we can start to share with the industry? I think it is, back to that creativity. We've got to think outside of the box, for sure.
Wonderful. And I think sorry, go ahead.
Oh, I was just gonna say, you know, again, like with the creativity, again, with our activities department, you know, our activities employees do have iPads, and, you know, when the patient is capable and when possible, if we can get a video going on just chair aerobics or something simple like that, because our activities department did conduct that kind of thing prior to the isolation. So when possible, you know, we're implementing that and really trying to leverage that technology to make whatever impact we can together.
Wonderful. I think, Pat, you mentioned, but there is a comment about a manuscript on the APTA website about Italian PT's response to COVID-19 and some recently published things. I don't know if anyone has, you know, some different resources or additional information you would want to share on anything you're seeing.
This is Judy. There are some great webinars that have been offered from the APTA. They're occurring on Saturdays, I guess, as a FaceTime thing, I think is the format. However, they're recording them, and you don't have to be a member. If you just go to the APTA site, you'll be able to access them, and they're excellent. They're long, but the one I just listened to from last weekend was broken down into different topic areas, and it was excellent. And so, you know, you could just, if you wanted to just listen to a certain section of it, you could kind of scan through the PowerPoint and then go to those sections. But there is a wealth of information on all sites, as Pat said earlier, and they're not requiring membership for many of these resources for the field, which is so wonderful.
And this is Pat. What I want to make sure to stress, I know there's a lot of you still on this call, and there are a few folks that had some great comments and questions that have had to leave. But what I think will be very valuable for all of you, and of course even the other folks, is we'll go ahead, Dahlia and I'll put together. It'll take us a day or two, but we'll take all of the comments, and then in closing, there will also an opportunity for you to ask questions or comment when this session is over. We'll take all of this, put it together, and then Judy and Stacy and Katrina, if you don't mind, we can share that with you for some additional comments. And then we'll also put the links to the APTA, the AOTA, and the ASHA on that document, and we'll distribute it out to everybody that registered today so that they'll have that with them. And maybe it will help provide some additional information.
That sounds good.
Yeah.
Great.
All right. Well, thank you all, and thank everybody that attended today. We know your time is extremely valuable, and thank you so much, Katrina, Judy, and Stacy, for helping us by presenting. Thank you, all of you, and we really appreciate everybody on the call, and thank you. You guys are dear to our hearts, and the heroes, and we appreciate you very much. Please note that if you have not attended, we do have another training session coming up about the focused infection control survey. So if you haven't attended one and you want to do that, please don't hesitate to reach out, and we'll let you know information about that as well. And again, that's just a service that we're providing to all of you out there that are caregivers, and to thank you so much for your service. With that, this will conclude today. Thank you again, everybody.
Thank you, Pat.
Thank you.
Thank you.
Bye-bye.